those. So yes, I'm going to talk about the surgical part of melanoma, which is just one piece of it. And I'll try to sort of address this both kind of like I would talk to patients, which actually in most cases gets reasonably technical because their questions are. I'll hopefully just use this one graft, which is from what we call SEER data, which is Medicare data published by our government, but it sort of shows the two roles that surgery plays in the management of melanoma. If surgery can be curative for melanoma when it's localized, meaning just in the skin where the mole is or maybe very nearby, it has a role and sometimes can be curative or therapeutic. Also, if there is regional involvement, as you can see here, though clearly the prognosis can go down, but it's still not a very bad prognosis. And these figures, by the way, are without many of the treatments Dr. Cowie is going to talk about. So surgery is important in the treatment of primary and to a degree regional disease. But one of the things this graph also showed is if you don't stage the patient, that what might normally be a very good prognosis actually gets sort of watered down with some patients where you didn't know they had regional disease. So the second job of the surgeon is to help stage the patient, find out about lymph node involvement, so we can provide that information to Dr. Cowie and his colleagues and sort of be able to customize the care of the patient. So two roles. So these are the things that I'll hit on. What I just mentioned is using surgery to treat localized and regional disease. Some of the decisions we go through as surgeons in terms of how much tissue, which is also involves how we're going to repair it. Dr. Wilder showed some very good photographs of that. But there are many things that go into this, and I'll discuss this in the context of the national guidelines that we follow. And we're also involved in biopsying lymph nodes, and we'll talk a little more about that, the so-called sentinel lymph node biopsy, but a little bit on the actual removal of lymph nodes. So just to emphasize the thing about melanoma, it has both a horizontal growth, meaning the mole can get bigger and wider, but it also has a vertical growth where it really gets dangerous. And the point of this is the melanoma, as it grows below this dermal epidermal junction that Dr. Wilder talked about, it gets into an area of skin where there are blood vessels, and these little green lines are lymph channels, so that these cells can at least get close to avenues of spread, as opposed to when it's all up here, there is no exact blood flow or lymphatic flow unless it gets very close to this. So the feature of melanoma, both horizontal and vertical growth. Unlike some skin cancers like squamous cell carcinoma and basal cell carcinoma, which tend to have a longer horizontal growth phase before they start growing deeper. So these features of melanoma make it very important for us to determine that. And that information comes from the biopsy that the dermatologist does. That actually has the majority of the information we use to determine how we're going to do a surgical excision. Point being, if in this top slide, in this top picture, we have diagrammed a melanoma in situ where the cells have not gone below this dermal epidermal junction, have not gotten into the area at risk for getting close to lymphatics and blood vessels. And so the treatment of this would be complete excision with a clear margin, with the guidelines, as mentioned before, that can be 5 millimeters, but really just clear margins. It can be done by surgical technique or Mohs micrographic surgical technique, and once removed with clear margins, it's curative. However, as the vertical growth becomes a little more advanced, and again, this information comes from that pathology report that the dermatologist provides us, then we are getting at risk. And these diagrams are showing both growth to between 1 and 2 millimeters of depth. That's that Breslow's thickness. And occasionally they ulcerate on their own, which is also a sign that usually if it ulcerates, it's also gotten into the dermal layers. So just to summarize just this first phase, our surgical decisions are based to a large part on the pathology. It gives us an idea of the prognosis, like from that first graph, and the likelihood of cure with surgery. It tells us how wide to excise and how widely we excise, and the part of the body where it's located, how we're going to repair that, because in repairing, we also want to restore form and function and appearance, at least the best of our capability. And it also provides us the information on doing the lymph node biopsy. This reiterates what we just said, and this particular drawing is showing, also as Dr. Wilder showed, that the T stage, the farther down into the dermis it gets, the thicker it gets, and the more at risk the lymph nodes are. Now, this is a secret. This is one of my favorite slides to show the students and residents because it's an incredibly inaccurate diagram, but that's why I try to go through it quickly, and you can't realize that they got the epidermis wrong and all this other stuff. But the big point is the deep part of this is near the red and blue squiggly lines and sort of the greenish yellow lines of lymphatics, and that is true. But what is more accurate are the NCCN guidelines that we use in a lot of surgical and medical oncology. The National Comprehensive Cancer Network publishes these. It's an ongoing process. And regarding melanoma, we have clearly established guidelines, and you notice they use the word guidelines, for how much we should excise around a malignant mole, a melanoma, or an in situ melanoma. Now, you notice they say guidelines. Keep that in mind. I don't know if you remember in Pirates of the Caribbean, but when the bad pirate was being made to walk the plank, the captain said, well, you broke the pirate rules, so you have to walk the plank. And he contested and he said, well, I mean, technically I didn't break the pirate rules. I can't remember what it was he broke. And that's when the captain says, well, they're not really rules, they're more guidelines. And so these are guidelines, which means we use these, but as down here in the very lower part, margins may be modified to accommodate individual anatomic or functional considerations. And one of the points also made before, if a patient has a melanoma in this mid-range, we normally try to remove 1 to 2 centimeters of skin at the narrowest point around it. But in some places you can't do that. If you have a melanoma, if it's close to the eye, or if it's in the ear canal, you don't have 1 centimeter or 2 to remove. Or if you do, you're causing an incredible functional impairment. So sometimes the anatomic location and needs for repair will modify that. NCCN guidelines. So this just sort of depicts how we use those guidelines, and the guideline or required width of excision is these little red arrows here. And as Dr. Wilder pointed out, this dictates the minimum amount we need to get around this malignant mole to have an assurance of minimal to no possibility of local reoccurrence. It's been established through studies. But we have to make it longer than we do wide, because if we don't, you just got a circle and you try to sew that up and it looks lumpy and it doesn't look very good. So this elliptical excision is a well-established surgical and dermatological principle for creating a straight line, at least as best as we can. So if we had 2 patients, if one had a melanoma in situ, this would be a 5 millimeter margin, and if it was a 2 millimeter deep melanoma, this would be a 2 centimeter margin, and that will dictate also how we repair it. So the guidelines tell us how much we remove, and then how we repair it. It may be a primary closure, which means we sew it up. Sometimes that amount and the location dictates we can't sew it up effectively. There's certain areas, like you saw in the picture, if it's on the nose, that skin doesn't give, you can't sew that up. If it's on the shin, lower leg, very frequently those have to be repaired by additional tissue. There's two kinds of grafts, what we call a split thickness skin graft, where we have a special knife that will cut a very thin section of skin that's sort of right through horizontally the skin, such that that skin can be taken and applied to a defect, a surgical defect that we've created, and it'll grow, it'll take, and new skin will develop there. But we've left behind enough of the elements of the skin that skin will regrow there also, so we don't have to repair that one. Now that's used for larger defects. You know, skin grafting is used a lot for burns who have huge wounds. But smaller wounds, usually about 5 centimeters at the most, we will sometimes take a full thickness graft, which means we remove all the layers of skin from the donating area, sew that in place, but then now we've created another wound, and we have to be able to repair that, and that has to be sewed up or repaired. Again, there are advantages and disadvantages. A split thickness graft allows us to cover a larger area. They tend to take or grow earlier in the course of things, but they also take much, much longer to look really good like normal skin. A full thickness graft is a little slower to take, but it will be, by definition, a more like skin in terms of its layers, color, and so forth earlier on in the course. And then sometimes we can't do either of those, and there are things called flaps, and we'll usually ask for our plastic surgeons to help us in terms of moving other adjacent tissue or other tissue into the wound to cover the defect. Could give a whole talk on these next 3 slides, and it's kind of interesting how art and science sort of intersect, and I'll explain what I mean by that. But these are fairly standard medical illustrations of the lymphatic system, both in the full anatomical size and in the microscopic size. And it shows this human body with this system of tubes with green stuff in them that go all through the body, and in certain regions like the groin and under the arms and in the neck, there'll be lymph nodes, sort of local intersections where the lymph is held up, and an incredibly complex system of immune surveillance goes to work on it, figure out what they are, decides is it something we want to kill or can we let that pass through. Thing is, they aren't green. I've been doing this 35 years. I've never ever seen a green lymphatic, ever. And over here, this is very standard artistic rendition. Arteries are bright red, veins are blue. Well, in real life, an artery is sort of a grayish pink, unless you've cut it open, in which case it's that red. And veins are more of a dark red because in the healthy state, they still have a fair amount of oxygen, which is what determines whether the blood is red or blue. Doesn't matter. Artists have to be able to demonstrate things. And of course, it shows the green things in here, which is a separate system, and it is very important. Fact is, it took us a long time in medicine to really describe and define the lymphatic system compared to many, many other things. And back in the 17th century and so forth, the only way that students of anatomy and those investigating medicine could study the human body was on cadavers, and there were a lot of laws and some fairly strict felony laws against grave robbing and doing anything, such that in much of Europe, the only cadavers you could get would be recently executed criminals. And that's an example here. Frederick Rusch, who was a very famous Dutch anatomist who described many, many things, but one of which he gave some of the first detailed descriptions of the lymphatic system. And we figure this is him because he's sitting there and he's not doing the hard work, and he's got a chief resident like Dr. Wilder over here actually doing the work. In these days, they didn't know about gloves and masks and stuff. But now this artist, this picture is interesting because supposedly it was a recently executed hanged convict, and the forensic pathologists criticize this because they say, If somebody dies from hanging, they don't lay in this position. And I won't describe what position they lay in, but the neck's not that straight, and they don't usually comfortably bend the knee up and prop it like that. It doesn't matter. It's art, and that's the key thing. But if you key into it, you will see what I'm talking about. He got it right. They're clear. They're clear as water. You can't see them against the other tissue. He's got little lymphatic channels, or his chief resident has little lymphatic channels there, and these are nodes, and in fact, in real life, that is what it looks like, which is why in the last thing I'll talk about, lymph node biopsy, we have to use some techniques to be able to find these, because normally they're clear, and when you look in tissue, you don't really easily see them. Many of these lymphatic channels are one cell layer thick, so it's pretty small. You're gonna have pretty good eyes. So my job, in addition to determining the width of excision and how to repair it, is to remove a lymph node in the region of drainage of the melanoma called a sentinel lymph node. Sentinel in that we've determined that these follow sort of an orderly pathway that's unique to every patient. I can't define exactly which lymph node would be for every patient without studying that patient. And to provide Dr. Cowie and other oncologists the information they need, I need to be able to remove that lymph node, but I need to be able to remove just that lymph node and not disrupt this entire lymphatic basin or remove too many lymph nodes. So that begins this process of what we call sentinel lymph node biopsy, which is diagrammed here. So the first thing that happens on the day of surgery, and many folks here have undergone this or something like this, our nuclear medicine department will inject a weekly radioactive material. It's called technetium sulfur colloid. And the nuclear medicine department does that. Rarely will your surgeon do that, because handling radioactive materials, thank goodness, requires a special state license and a lot of regulations. So in most hospital systems, it's got to be done in the nuclear medicine department, where they have radiation physicists and people that comply with that. So that's a good thing. It is sometimes a little unnerving when the day of surgery you get to meet another new friend who comes at you with a needle. But they're very compassionate, and I think overall they do a pretty good job. They inject this material, and it's designed, the particle size, the molecular weight of technetium sulfur colloid is such that it will preferentially be taken up by lymphatics, and it takes it usually 20, 30 minutes to migrate to the sentinel nodes that will hold it up for anywhere for 2 to 3 hours, depending on the size of the technetium sulfur colloid particle. And that allows them to then take a nuclear medicine image with a special gamma counter that will actually map out a picture of this, and it'll show the hot or sentinel lymph node. Then you go to surgery, and at surgery we might inject a blue dye if we want to color the lymph nodes. It isn't the most common technique. The radioactive material technique is probably the most common, but there are some parts of the body where we do use the blue dye. It's important to know, because you may come through your surgery quite successful, but then you look down at your arm and it looked like you've got a prison tattoo there for about 8 or 9 hours, but it always goes away. Then that allows us to go to surgery. We do the wide excision, just as we described before, and we have a handheld probe called a gamma counter that tells us exactly where the most radioactive node is. Then we can make a relatively small incision there and remove just the radioactive lymph nodes. And that allows us to provide prognostic information about the regional node status of this patient. Again, seeing where just the 1 or 2 lymph nodes, and whether it's 1 or 2 or 3, has to do with the radioactivity count. Our rules, our guidelines for that are we have to remove the radioactive count by 90%, whatever the count is. Once I've taken the radioactive 1, 2, or 3 nodes out, we don't want to have any more than 10% remaining, and that's sort of how we define radionuclide-driven sentinel lymph node biopsy. And then it's out. These look a little bit blue because in this example we injected the blue dye. So to sort of summarize how we use that information, patient A, say, has a melanoma in situ on his leg. We treat that with wide local excision with, as we said before, 5 millimeter margins. It can be done with surgical technique or Mohs micrographic technique. Usually you can primarily close that, depending on where on the leg it is. With the final report being melanoma in situ, all that patient needs is good close follow-up with their dermatologist. They still, of course, as was mentioned, are at risk for other moles to undergo suspicious change. But patient B, let's say, has a 1.3 millimeter thick melanoma. That was in that range where there can be a greater than 5% probability of spread to a lymph node. So they have a wide local excision with 1.5 to 2 centimeter margins based on those guidelines. We do the sentinel lymph node biopsy on the day, and therefore we have the primary area treated and repaired and the sentinel lymph node biopsy being processed. Two outcomes: if the lymph node is negative, doesn't have cancer cells in it, then that patient will be closely followed by his medical doctor, who needs to know the history, still seeing the dermatologist on a regular basis for surveillance, and in our particular culture here, the surgical oncologist will follow them, or if they're already in the practice of a medical oncologist, someone will also be following to evaluate other lymph nodes and those kinds of things. Contrarily, that's a term from Sopranos, by the way. I don't think it's actually an English word, but Christopher would use that. You know what he means. Au contraire, if it's positive, we go to the next level. Needs to have complete staging, check, make sure there's not melanoma anywhere else, and will routinely need consultation with a medical oncologist to help in the collaboration and decision about further lymph node surgery, should they have medical treatments, which will be discussed a little bit later, and so forth. Now, I'm not showing a lot of pictures about the radical lymph node dissections and so forth. That takes a lot of time, but it obviously is certainly a part of surgery in the appropriate cases. Some of the medical names that you all know that have been applied to these are radical neck dissection. Don't usually do that for melanoma. Modified radical neck dissection or selective neck dissection, which are frequently done with melanoma. The lymph glands under the axilla or armpit or axillary lymphadenectomy, an operation similarly done for women with breast cancer, or removing the groin lymph nodes, inguinal, ilioinguinal, inguinofemoral lymph node dissection. Sometimes we call these radical groin dissections. Now, these are a big deal. For these reasons, 20 to 40% patients who have these extensive lymph node dissections will have some long-term swelling called lymphedema. There are things we try to do to prevent it, but it's just a known consequence. Now, it's important in the same context to remind us that lymphedema is a treatable condition. Here at Baylor, we have a full lymphedema clinic, which can both do testing to see if a patient is at risk for getting lymphedema before they actually get the lymphedema. It's called impedance testing. But they also, more importantly, if you are starting to get it and are aggressive in the first 6 months, can be totally controlled and managed. Also, after a lymph node dissection, you'll frequently have some local numbness. That's usually less of a bother. It almost always goes away, but it can take many months to go away. And also, there's some predisposition, I use these words carefully, predisposition towards difficulty with infections should they occur in the involved part or extremity. I'm not convinced they're at increased risk for getting an infection, but if one occurs, they can have a hard time getting it out of the extremity because the lymph system is sort of the flushing out of a lot of the fluids that's not blood, and that's impaired with this. So this is important to remember, and in patients who've had lymph node dissections, they're always cautioned, if you're going to go out and work in the garden, you need long sleeves and long gloves. If you get a nick or a cut, you don't wait till you finish weeding the flower bed. You go in right then, you wash it off, you clean it off, you treat it like any other nick. So that's an important thing to remember. Now, all that being said, I'm obviously not trying to talk people out of having lymph gland surgery if they need it, because the fact is, if there are malignant cells, malignant lymph nodes in the area, and to our best knowledge, that's the only place they are, statistics show that by removing the malignant lymph nodes, we improve that patient's survival. So that's a risk-benefit of this part of surgical treatment that clearly needs to be discussed carefully with patients as they make their choices. So it's an important thing, and the majority of patients will accept that kind of risk when they understand that risk-benefit ratio. So just to summarize, we talked about the use of guidelines and that pathologic information the dermatologist provides us with their biopsy, both in treating the localized disease and how we approach and treat regional disease. Some of the thought process your surgeon may go through in determining how much tissue to excise and how to repair it, which needs to be discussed in the same context of I'm cutting this out and also how I'm going to repair it. We talked about why and how we biopsy lymph nodes, called a sentinel lymph node biopsy, and how we technically go about removing those. So that kind of covers the surgical part of things. And I do want to once again thank AIM for helping set up and facilitate these sessions. It's extremely important, and it adds an incredible layer of legitimacy to these kinds of things. And you know you've always got an advocate currently in the back of the room, but available to you by any one of a number of means.